All right, today we are jumping into a classic clinical puzzle. You've got a patient with acidosis, but a completely normal anion gap. Now this can be a real head-scratcher, but trust me, by the end of this, you're going to have a foolproof flowchart to solve it every single time.
So, just picture it. You have a patient, they clearly have metabolic acidosis. You run the numbers, you calculate that anion gap, and it's normal. This, my friends, is NAGMA, normal anion gap metabolic acidosis. And just like that, your usual suspects, ketoacidosis, lactic acidosis, they're all off the table. So where do you even go from here? What's your first move?
Well, it turns out that there is one single calculation that can crack this whole case wide open. It's like the master key that splits the entire list of possible diagnoses into two very distinct paths. This is your absolute starting point.
So what is it? What's that one test that splits the world of NAGMA in two? Go on, take a second and think about it. What would you calculate next to figure out what's really going on with your patient?
It all comes down to the urine anion gap. Yep, this simple calculation using urine electrolytes that are super easy to get is the critical first step. It's what separates causes of bicarb loss from the GI tract versus from the kidneys.
So how does this actually work? Well, the formula itself is pretty simple. Urine sodium plus potassium minus chloride. But the real magic is that it acts as a proxy, a stand-in for urinary ammonium. See, in metabolic acidosis, healthy kidneys should be working overtime, pumping out a ton of acid as ammonium. The UAG basically tells us if they're doing their job or not.
And right here, this is where our diagnostic path splits. The result of that UAG, whether it's positive or negative, creates a super clear fork in the road. It's going to send us looking at either a gastrointestinal problem or a kidney problem. So here's how we build our little algorithm. If the UAG is negative, that means the kidneys are working hard. They're appropriately getting rid of acid. But if it's positive, that tells us the kidneys are actually the problem. They're failing to excrete acid properly. Two totally different scenarios. Let's break them down one by one.
Okay. First up, case number 1. Your patient's urine anion gap comes back negative. Now this is actually good news for the kidneys. It means they're responding to the acidosis exactly like they should be, by dumping a whole lot of ammonium. So if the kidneys aren't the problem, where is all that bicarbonate disappearing from?
And the answer points straight to the GI tract. A negative urine anion gap in the setting of NAGMA is a huge clue pointing to gastrointestinal bicarbonate loss. And the most common cause for this by a long shot is severe diarrhea.
All right, now for case number 2. This time, your patient's urine anion gap is positive. This completely flips the script. A positive UAG means that even though the body is acidotic, the kidneys are slacking off. They are failing to get rid of enough acid. The problem isn't outside the kidneys, the problem is the kidneys. So what's our diagnosis?
A positive UAG points directly to a renal cause. Specifically, it suggests the kidney tubules themselves just can't handle acid properly. This condition is broadly known as renal tubular acidosis, or RTA.
Okay, so we've nailed it down to a renal tubular acidosis, but we're not quite done yet. Now we get to our final challenge, a quick rapid-fire round to figure out which major type of RTA we're looking at. You know, another common lab value can help us sort through the most frequent RTAs. Can you remember which types usually come with low potassium, and which one is famous for having high potassium?
And there it is. This is a really crucial distinction. You've got your proximal RTA, which is type 2, and your classical distal RTA, type 1. Both of those typically present with hypokalemia. That's low potassium. But in sharp contrast, you have generalized distal RTA, type 4. That's the odd one out. It classically presents with hyperkalemia, or high potassium.
So, let's put this all together. In just a couple of minutes, we've built a really powerful and repeatable diagnostic algorithm for tackling any case of normal anion gap metabolic acidosis that comes your way. So here it is, the whole algorithm in 5 simple steps. You start with NAGMA. Step 2, you calculate the urine anion gap. If it's negative, think GI loss, like diarrhea. If it's positive, think RTA. And then step 5, you use the plasma potassium to start telling the different RTA types apart. It's just an elegant and incredibly effective approach.
You know, this quote from the source material really sums up the core logic perfectly. A negative UAG means the kidneys are doing what they're supposed to do. A positive UAG means they're not, and that points to a renal problem as the root cause. I mean, that's the entire principle right there, in a nutshell.
And there you have it. You've cracked the initial case, you've spotted the diagnosis. But you know how it is in medicine. Answering one question always leads to another. Now that you suspect a specific RTA, the deeper investigation into what actually caused it can begin. But for now, you are on exactly the right track. That's all for now. Keep questioning.